Dr. Kyle Resendes. I'm an ER doctor, live out towards Richmond. Did undergrad at Virginia Tech, medical school at MCV, VCU now, I guess. Then went out to the beach at Eastern Virginia Medical School to do residency and moved back here and have been practicing within kind of the HCA system for the past 3.5 years. It was a psych doc that I had gone out to grab a beer with. He was like, dude, you like everything. Like, it's plain as day you're an ER doc. Like, just go back and do another rotation in the ER. And I did, and I loved it. And it was just like, yeah, this makes all the sense in the world. I loved all my rotations. I still get to see everything. I still get to see the orthopedic injuries. I still get to do all my own fracture and dislocation reductions. But I'm not on call. I don't have to spend 6 hours in the operating room. I also get to deliver babies and see heart attacks. Like, I don't just get to focus on one thing. I can kind of do the Swiss Army knife of medicine approach, which is pretty sweet. Was in residency, there was a judiciary conference out at Virginia Beach. So I had a bunch of old judges who were all getting together for a conference with or without their significant other who were out drinking and out partying. So that weekend we had more strokes than we had ever had before. We had a bunch of broken hips, torn ACLs that came through from a bunch of old judges who were coming in and, you know, doing their recreational activities outside of their conference stuff. And we had a guy who came in, chest pain, went diaphoretic in the waiting room, had a STEMI on his EKG. I'm an intern. My attending Dr. Graffio grabs me and he's like, all right, first year, let's go. So we walk back there, hands me the EKG, he goes, what do you want to do? I'm like, I think I want to do aspirin. And I think I want to do a heparin drip. He's like, that's a good idea. You want a bolus with the drip? I'm like, yeah. And as we're talking this over, Dr. Graffio was like our patient whisperer. He's talking to the guy. He's just asking him general questions. How you feeling? He's like, it hurts. I'm a little short of breath, but I feel okay. And he starts asking him about the conference. And so him and Dr. Graffio are chit-chatting as I'm getting all the orders and everything together. And as they're talking, his eyes roll into the back of his head and you look up on the monitor and he's in VFib. He's already on the pads. I say, shock him. So they shock him and he wakes back up. And he immediately wakes back up. And Dr. Graffio keeps talking to him about the conference. Like, he was just having this casual conversation. It happened 3 times where he would go into VFib, we'd do 2 seconds of CPR, you'd shock him and he'd wake back up. And he'd have no idea that he had just died. None. And Graffio, calm, cool, collected, was on the FEMA emergency response team, trained in New York, just had the gift of gab, would just be like, tell me about your grandkids again. You remember that? You were just telling me about it. And like talk this guy through dying 3 times so he could get him to the cath lab, which was crazy to me. And so like a STEMI and VFib, maybe not the most interesting things in the world, but like that approach and being so calm and so cool and so collected and not even letting the patient know that like, oh, you're crazy sick. Crazy sick. You just died 3 times in front of me. I mean, my intern fixed you, but just to have that kind of approach was amazing. I'll never forget that. I think emergency medicine as a culture, nursing staff, physicians, paramedics, techs, we're kind of, I feel like we're kind of the cowboys of medicine, where there has been a lot of, all right, we're gonna get in, we're gonna immediately act. We can think about this in 2 seconds. Just, we gotta get the patient stabilized. We can MacGyver anything we need to. Like, that's kind of our MO, is limited resources. I can still do almost anything. What I think the pandemic has done, I think to me specifically, has maybe been a little bit of like pulling the reins a little bit on immediately run in, you've got to do something immediately. You can still do all of those things, but take the 2 seconds beforehand to say, all right, this patient is coming in with stroke-like symptoms. We didn't get a temperature check coming in, right? We know COVID-19 puts you at huge thrombolytic risks or thrombotic risks. These patients are coming in with strokes and pulmonary emboli. You're putting them on a launch pad, which is out in the open. When they get there, remind your nursing staff, make sure you have an N95 on if a big stroke is coming through and they have any sort of respiratory component. Make sure you're screening their temperature while they're on there as well. Like, yes, they're still going to need TPA, all those sorts of things. But you've got to be thinking about kind of the overarching picture of this virus has changed our landscapes a ton, and we have to act in a way that's a little bit more thoughtful to protect ourselves, right? Because we can't help anybody if we're all getting sick or if we're getting repeat exposures. It's a little bit of just a check on, all right, I got this. I'm an emergency doctor, you're an emergency nurse, we're getting in there, we're gonna fix it. It's like, all right, let's take 2 seconds. Just take 2 seconds to make sure that we're safe too, so we can help more patients. So I actually have one under here, which is a line of text. My cousin passed away 2 days after my high school graduation. She was 21. She had diagnosed with leukemia when she was 20, and she went septic after having a bone marrow transplant, rejected the bone marrow transplant. There was nothing else that they could do. But before going in for the bone marrow transplant, she had started writing poetry. And so my brother and I actually have 2 lines from a poem that she wrote. And it was funny because she was kind of a tomgirl, and she was not someone, like, she was tougher than me. She was not someone who was very mushy, and you wouldn't expect poetry. So when her mom started reading them to us, we're like, oh my God, this is amazing. So mine is, I think, a pretty unique, approach to her sense of, I could die from this. And there's a line in the poem that says, I was given the chance to take an unwanted journey, which is kind of how she approached like the whole battle with cancer and everything, which I thought was amazing. Like, that's not something that you can say or that you can reflect on without being put in that situation. Like, it was amazing. So I have that right here. That's definitely my favorite one. My little brother has the opening stanza to that on his chest. All of these, they're all medicinal herbs. They're all very meaningful to me, but that one right there is the one. I think the only people that see more excited delirium patients than me are our paramedics, right? And now you've got, depending on where you work, which county you're working in, you have like all of these extra tools. Do I use ketamine? Do I use Versed? Am I trying to redirect the patient just verbally? Do I have to put them in restraints? Are they so out of it that I'm going to hit them with all of that and hope I can actually get them into the back of my ambulance? Pray to God that they don't have a head injury that's causing all this. So a few paramedics have asked me, because every time I walk into these rooms, regardless of how aggressive the patient is being or how much psychomotor agitation they have, the first thing you look at is their eyes. And it tells you almost 100% of the time, what did they take if they took anything, right? Psychiatric patients, you're not going to have, true psychiatric patients, schizophrenics going through a break, bipolar manics with schizophrenic features are not going to have dilated pupils, constricted pupils, nystagmus, things like that. That's a whole different round. But as far as intoxications go, you can tell a lot by looking at a patient's eyes, right? Like, all of us know the pinpoint pupil with someone who's somnolent, they're going to get Narcan. You're not giving them benzos, you're not giving them ketamine, you're giving them Narcan because you recognize they're in an opiate overdose, they're bradypneic, they're bradycardic, they're hypoxic, they're pinpoint pupils, look pale, they're about to code, slam them with Narcan, they wake up, they maybe spray the back of your ambulance and vomit, but they're alive and you've done your job, you've saved another life, drop them off at the ER, we got this. The ones that get really, really interesting though are, and it's not that prevalent necessarily in our region, but if you go a little bit farther north into the state of Virginia around DC, PCP is huge, and it's starting to trickle down, right? And it's got a really, really interesting kind of ocular finding, and it's a really good thing to recognize because it helps paramedics and EMS providers from making the situation worse if you can recognize it, right? So if you have someone who's super, super agitated, diaphoretic, and they have vertical nystagmus, or this kind of really, really quick beating of the pupils kind of up and down, or you actually physically look at the eye and you can see it kind of twisting like this, rotary nystagmus, vertical nystagmus, and mild pupil dilation, PCP every single time. The only other thing that really happens with is someone who's having a really, really bad basilar stroke, and they're going to be slurred speech, very, very dizzy, older population. This is usually young, otherwise healthy, their heart rate's through the roof, their blood pressure's through the roof. If you recognize that, you've got ketamine and you've got Versed in your truck, right? The ketamine goes out the window, right? You're going to make their tachycardia worse. There's a potential that you put them into laryngospasm. You're never going to intubate that person. That's a patient who needs benzos all day. Just hit them with Versed if you see rotary nystagmus, psychomotor agitation. Because the other thing is they're hallucinating at the same time, and it's a stimulant. Ketamine is almost the exact same thing, right? So you hit them with ketamine and they're good in the back of your ambulance for a little while. 35 minutes later, I'm intubating them because I can't control them anymore. So that's a cool one to be able to recognize. The other things, like whether they have markedly dilated pupils from LSD, is another one that'll give you huge pupillary dilation. They're usually not as agitated. That usually comes with dilation and cocaine and methamphetamines. That's when they get really, really aggressive. But the LSD, cocaine, methamphetamine, no nystagmus, but big dilated pupils, right? And so being able to look at the eye and say, oh, that's a really rare finding, that helps me manage not only from a long-term perspective from when I drop them off in the ER and making our job a little bit easier, specifically the nurses, because it's really not, it's not hard on me, it's super hard on my nurses. But to be able to recognize that as, that's a really, really unique finding, and it helps me decide which medication I'm gonna use before we even get them to the hospital, is huge. And then if you ever see one pupil bigger than the other, just call the code neuro and we'll meet you at the door. One bigger than the other and they're agitated, they're stroking out and it's a bleed. Just get them here as quick as you can.
Okay.